angulation of the tooth, and the distance from the cusp to the pulpal floor. And then also doctors will reference the laws of pulp chamber anatomy, which we'll talk about on the next slide. But once this is all completed, the doctor can identify the initial access point and place the burr in their handpiece to begin access. So the laws that I was talking about, there's 9 of them, but these 3 are really the ones that doctors reference a lot in all of the different PowerPoints and things that I was reading. This continually kept being referenced. So that first picture there, law of centrality. So basically, pulp chamber is always at the center of the tooth. And then the law of concentricity, that word is so difficult for me to say, it's a tongue twister. The external root surface reflects internal pulp chamber. So on the occlusal, if you have a little bit more raised parts in the occlusal, that gives you an idea of where that pulp chamber will be. And then the law of the CEJ, the distance from external surface of crown to wall of the pulp chamber is same throughout the circumference of the tooth. So on that third picture there, you can see all the way around the tooth, it'll be the same circumference. And then this is just another slide showing shape of pulp chambers in your anteriors, premolars, and molars. Primarily, that's usually what the shape of them, and that's the guide that doctors will use when determining access points. Okay, now when we're removing the pulp chamber, first and foremost, we want to make sure all caries and defective restorations should be removed. This was referencing earlier. This is where infections can come in if you lead to, or if you leave any of the defective restorations or caries. And then the shape and type of burr depends on doctor's preference, but typically a round burr is used to initially access. Those round burrs are used for dental removal. They'll drill through the dent until they feel a drop into the pulp chamber. The same burr is also used to remove that roof of the pulp chamber. And then whenever you're sloping the sidewalls, this is where a fissure burr can be used. And this is where you also really want to make sure every office has a safe end burr when doing endo, because these safe-ended burrs are going to avoid damaging the pulpal floor when they're shaping that access. And then the doctor can determine the access is complete once the color change is detected. So the surrounding walls will be much lighter than that pulpal floor. And then I just included here as a warning, when doctors are using tapered burrs, they should never be forced. I mean, really with any of the burrs, they shouldn't be forced because then that will actually weaken the tooth. So this is a little bit longer of a video. You know, afterwards, if you guys want to really get in deep with the endo access, it's about an 8-minute video, so I'm not going to play it, but it's a really good resource, and it has a lot of different terminology that you can use when referencing access points. So, so for the access burrs, we're now going to get in, Jeff and I are going to get into the Alpin line and all the different Alpin products that we can suggest when talking about endo access. Like I said before, it's usually initiated with a round carbide or fissure burr. Doctors are usually trained to use 2, 4s, and 6s. Of course, the higher the number, usually the wider the pulp chambers. So the 2, of course, mandibular anterior teeth and maxillary premolars with narrow canals, and then as you go up, your 6 is going to be in your large pulp chambers. They're also using the 557s, 1557s, and 1558s. And Jeff is actually going to talk to you more in depth on our Alpin line.
Okay, thank you, Melissa. So our Alpin line is a little bit unique of a product. It's a one-piece constructed burr. So most of the ones out there that we see are a 2-piece. So you have a shank with a welded head on top, and that's where you get weak points in the junction right there. You might get some breakage. You might get a lack of concentricity, which creates chatter in your handpiece, so wear and tear in your handpiece, or you might get some rusting. So our Alpin burrs are very, very high quality burr out there. We do offer the number 2, the number 4, and the number 6 round carbides in 10 and 100 packs. So the round burrs, like Melissa was talking about, we have those available. We also do have a lot of different other options too, like our Alpen Speedster, which is great metal cutting burr. It kind of cuts through everything. It's a very aggressive burr, great for amalgam, porcelain, PFMs, and those are available in those 2, 4, and 6s as well. So you know, if they need to get aggressive, we have that available, or we have our regular round carbide. Next slide, please. Melissa, you awake? There you go. As far as Alpen diamonds, we have a ton of different styles and shapes, but with the rounds, we have the rounds, we have the round end tapers, we have the long round end tapers. Our diamonds are very, again, a very high quality diamond made right in house that we make right in Ohio. So we have any kind of shape or size that a lot of doctors will use. It depends on their preference. Next slide. So one question I always get asked is what about ZR Plus, or what about porcelain crown? And we have a tremendous product for this. It's the Alpen ZR Plus diamond. So what this is, it's a synthetic diamond made to go through synthetic material. It comes in a fine grit, so you're not going to get a lot of the chatter of the excess, the endo excess. It's going to be, you're going to resist the microfractures in there. We have a couple different we have actually several different shapes, but one thing I want to focus on is the bottom shape is the inverted cone. And a couple years ago, we actually had the person that makes these for us come out and speak to our company about these burrs. And he took this inverted cone through a zirconia crown, and he put the inverted cone at a 45-degree angle. And all he did is he tipped the inverted cone up straight 1, 2, and then 3 times, and he created a beautiful, nice circle right through the zirconia crown that creates that minimally invasive access that we want to, and they're not burning through, 4 or 5 burrs, which is what they typically do, where sparks are flying all over the place and damaging the restoration. So that's a great option for somebody going through zirconia diamonds, and they all have trouble doing it. So next slide. Like Melissa was talking about the safe-ended burrs, we do have safe-ended burrs, and what that is it's a non-end cutting burr. So you're not going to scar the pulpal floor, like we mentioned earlier. A couple different sizes and shapes that we have there, but just know that those are available in our Alpen line. Next slide. What about single use? So, a lot of this is becoming more and more popular. Canada has a lot of mandates that they have to use pre-sterilized single-use products. There's a lot of organizations in the States that have it like this too, and it's becoming more and more popular. And we have 2 different styles. We have our pre-sterilized carbide, which is our Sterex, which is individually packaged. Again, 1-piece construction. You have a lot of different options in this where, some of the pre-sterilized carbides out there are very limited. We have a lot of different options. And then we also have our pre-sterilized diamonds, which is our X1 diamonds. Again, pre-packaged, pre-sterilized, many different options. So somebody that is looking for that pre-sterilized single-use product, we have those available too. Next slide. So Alpen has it all from A to Endo Z. Going back to what our Alpen construction is, it's a 1-piece carbide construction. We have many different specialty lines, from our Speedsters to our Zirconia Plus, from our multi-use diamonds to our single-use diamonds. One thing that you can offer your offices is they're buying it right through their distributors. So we have a lot of specials that they can take advantage of. They can take advantage of any kind of rebates they're getting through, if they're getting any rebates through their distributors, and make it easy ordering one bill. So that's great to offer the offices. They can get a high quality product right from the place that they order the rest of their supplies. And remember, access is the key to a successful endo procedure. So why not switch to Alpen? That's all, folks.
All right. Great job, you guys. Thank you. Melissa,
Yes.
excellent job educating us. Hey, do you mind going back to that video slide? And I think one of the things that I learned from your presentation was the color change.
Mm-hmm. Yes.
Did they show that in this video?
He doesn't show it in the video. It's more the pre-access analysis. I mean, I didn't realize how much went into access until I did all this research on it. So it doesn't really show that, but there's a lot of pictures and things online that will show it.
Okay. Yeah. I mean, where did you come up with this presentation?
Well, I have a lot of different references at the end. So there's several different the LinkedIn Learning, Meredith sent me a really good presentation on there. That was super helpful. And then just like AAE, I utilize that website a lot.
Okay. Excellent work. I mean, yeah, definitely learned a lot. And I think maybe some of it I knew, but I think I forgot a lot about the laws of the root canal chamber. And can you go back one more slide, please? And one up, there it is. That one. Okay. Yeah, I remember on Albor's presentation, one of the things that he was talking about was through his microscope endo, he creates such a small access point that he can only see one canal at a time. And I mean, some of these are, I'm sure, older images, just kind of not real minimally invasive as far as access goes. But still, it's a great sort of overall anatomy of what you'll end up looking like. But excellent work on that. And then Loops, great job with the product presentation. Who would you say the biggest competitor is that we encounter for access?
Biggest competitor? I mean, I think that any kind of burr competitor with Brasseler, Midwest, I mean, those are the big ones that I see.
Who do you run into the most? Yeah, okay.
Those two, Brasseler and Midwest.
Okay. All right. Great job, you guys. Especially love the ZR Plus portion there, Loops. I mean, that's something that seeing REA do that demo, stuck in all of our heads as far as like how easy it is to access with our ZR Plus. And that's a good question. It's like if a GP is doing endo, there's a million questions you can ask, but if they're already using our files and they're already using our irrigating solutions, etc., you've got something else you want to talk about. Doing a lunch and learn, you bring this up, you're like, so if you're doing endo, how are you accessing that pulp chamber, those canals, in the presence of zirconia crown? And just see what they say, and then come to the rescue with what we've got. But yeah, great job. Thank you. Any other questions or comments?
Great job, you guys. I mean, there were so many points in there that are just new business that you don't think about with accessing. So great job. Thank you.
Thanks, guys.
Okay. And like I said, I'm going to share all these links to Google Slides, so you'll be able to access all these afterwards. But I'm going to, if there aren't any other questions, I'm going to turn it over to Sonia and Laurie, and I'll throw it out to you two. Which one of you would like to drive?
I can do it. This is Sonia.
Okay. All right, so let's jump into step 4, debridement. And Sonia, you got it. Okay, perfect. Go ahead and take it away.
So just kind of like a background history of hand files. At one time, root canal hand instruments were made like basically just kind of on a whim, manufactured. It was like the wild, wild west out there. There wasn't very much specifications regarding diameter, taper, length, or cutting blade. So in 1958, these two guys, Engel and Levine, they were the first to suggest that there should be a definite increment in diameter as the size progressed while maintaining taper of all of the blades regardless of size. So I'd say, yeah, in the mid 50s, there was actually some consistency that started with the manufacturing process of hand files. So just to kind of talk about
real quick, Sonia. Sorry to interrupt. Can you put it in presentation mode so that presentation takes up the whole screen, please?
Got it. That better?
Yeah,
can you
that's
guys see
perfect.
that now?
Thank you.
Okay.
Yes.
All right. So debridement. So following diagnosis and placement of the rubber dam and accessing the tooth, we're going to have debridement. So it's basically negotiating the canals to working length and establishing a smooth glide path from the canal orifice to working length, and this is with the hand files. Here you can see hand file instruments. They have a .02 taper. That's one of the things that I just mentioned that got standardized in the manufacturing process. And the .0 taper is commonly used to navigate the canal system to length. And of course, during this process, when you're doing that, you're going to use the appropriate irrigants such as sodium hypochlorite and or EDTA to facilitate debridement. And down below here, you can see the pictures. We're all familiar with these K files, reamers, and X files, and we're going to dive in a little bit more on each one of those. All right, so K files, so these are very popular. We always see these in our offices. Everyone just thinks about a hand file being a K file. It's kind of like the Kleenex thing, but these are going to be used for initial canal location and cleaning of thin canals. And you can see a picture there. And these are actually twisted files rather than milled files. The next one is a K-reamer. So these are used for the removal of debris. And again, you can see they are not quite as small or, not as many twists in the file, but it is also a twisted file. And then the last one we're going to talk about is H files. And these are used for more aggressive cutting. So K files. So these were developed early in the 1990s by Kerr, and they are square, triangular, or diamond in cross section, and they have an increased number of flutes. And these are used with a rotational motion as that rasping, pulling, watch winding motion to clean and enlarge the canal. And of course, like it says down here, primary files used in the you're going to use these by the push and pull motion and cut into the pulling stroke. And these are a lot more subject to fracture. So that's extremely important to note because they are easier to break when they're being used, just because they are used a lot during those retreatment and tricky cases. And then lastly, a glide path should be created with hand files and or rotary glide path files before we use the rotary systems. And then next, I'm going to hand it off to Lori.
All right, thank you. So as Sonia just said, hand files can vary by the manufacturing process, design, the cross-section length, handle design. So there's a lot of variations. K files, again, are going to be the most popular, what you see doctors using the most of, but the point is whichever hand file they choose is just that they are using hand files. So a good rule of thumb is never put a rotary file where a hand file hasn't been. So that's a little golden endo rule. If you're having a conversation with the doctor and they mention they just like to jump right into rotary, they don't really use hand files, we should probably get them signed up for an endo course and get them on the straight and narrow path of hand filing first. It's an integral part of the endo wheel and process. It's really just indispensable. And Dr. Albors, he really likes to emphasize using hand files. So that's our second rule of thumb. You want a hand file to at least a size 15 hand file. Ideally, even a 20 is even better. So in Dr. Albors' presentation that we just recently watched, he mentioned all of the issues that you can come across with the torsional fatigue, cyclic fatigue, dynamic torsional fatigue, all of these problems that happen. He thinks or preaches even that they can be eliminated through effective and proper hand filing first before introducing the rotary files into the canal. So again, extremely important, can't be emphasized enough. So next slide, please. All hand files have the ISO color coding, so it's great for easy recognition for the doctors. It's also good for us to know these, at least the most popular sizes, because if a doctor ever says, in which they do, I need a refill of your white hand files, then you automatically know, hey, they need a refill of the size 15s. So it's just good for everyone all around that these are all ISO color coded. Next slide, please. Oh,
Sorry, Lori, that went to two
no,
slides, so you should be on.
No, sorry. Okay, so even though we don't have our X files anymore, we have something, maybe even hopefully better, coming soon. Micro Mega hand files. Guys, remember learning about Micro Mega at our last national sales meeting acquired by Colteen in 2018. So they have a full line of hand files that will, I don't know the estimation on when, but eventually they will be in our bag for us to offer, which will be great to have. Since we say we have everything on the Endo wheel, it'll be great to have some hand files back in our bag to offer. Next slide, please. So just obviously we're going to be probably properly trained on these hand files before we get out there in the field and talk about them. But just a couple of things from their website that they told are the ergonomics of a hand file. It's a really good file grip. We all know that everything in dental is extremely tactile for these dentists. So having things like a good hand grip on the file is great news. Speaking of tactile sensation, that's a huge part of hand filing. Without hand filing, doctors can't really get a tactile sense of the anatomy of the canal by a radiograph alone. So if they're not properly hand filing, they're not going to be able to navigate
the anatomy of the canal as easily or feel what problems might be occurring throughout the rotary, such as curves and such. So just kind of, sorry, off track with the tactile sense, but also Micromega hand files, the radiopaque silicone stop for perfect adjustment to working length. So just a couple features of our hand files that we will one day be offering. Next slide, please. So hand files, there's actually quite a bit of competition out there. So it will, like I said, again, be good to have something in our bag to offer. Cybron, of course, is a big competitor for us because it's not direct as well. So it's something that reps are talking a lot about. So they offer K files, the Patterson brand or your Shine brand. They also make house brand K files. Again, like I said earlier, they're the most standard or common. So you'll see those the most, but those are a big competitor because they're just really economical, and you'll see those a lot. EDS Dental has safe siders. Those are actually reamers, but I see those in some offices sometimes as well. So a lot of competition as far as that. But hopefully, like I said, again, we can combat that soon. And next slide, I think that is all we have for you guys. Any questions?
Great job, first of all. Excellent work. First question, just because it's on fresh in my head, are most of the stoppers radiopaque?
That's a great question. That was actually the first time I've even seen a sales.
That's a good question. That was definitely kind of highlighted on the Micromega website for their hand files. So I guess we didn't research maybe on the K-File, like her brand. So we can dive into that a little bit more.
Yeah. No, I mean, hey, look, no worries. I mean, that was something like really popped out at me, but yeah, great work. Laurie, never put a rotary file where a hand file hasn't been. That's great advice. Love that. And then the other thing, Sonia, with the H files, again, I guess maybe I knew this at one point, but you just brought it home and really kind of emphasized the fact that the H file used in a push-pull motion and then used mainly in retreatment. And again, something I really didn't even think about or consider. So great job on hand files. And as far as the launch of the Micromega, I thought we were looking at Q3, Q4, but Amy said it's probably not going to be till next year for us to bring those hand files home. So sorry about that, but you know, this again is such an important part of the overall procedure for endo. You know, hand filing is one of those things that you have to do between each rotary file, right? I mean, between irrigating and reestablishing patency between each rotary file, it's the most important thing. So yeah, that's great job, you guys. I'll open it up the floor for anybody that has any questions or comments.
One comment that I have that I wrote down was just kind of talking about what Pete just said, the difference between the K-file, reamers, and H-files. Like, we hear those so often in the field, but we're really only dealing with K-files for, you know, along with what we're selling, our rotary files, right? But the difference is kind of, just to keep them straight, K-files is scouting the canal, and reamers, typically like a pulpotomy, like the patient comes in with a real hot tooth and they want to get in there, and just like in one piece, they can use a reamer to get that whole entire nerve out, kind of like a little leech, how it comes out. And then the H files, we talked about the retreatment with calcified canal. So that was a good slide, kind of just figuring it out for me in my head too. Good job, guys.
Hey, Meredith, have you ever been chairside when they pull the leach out?
Oh yes, it's so exciting. I mean,
What do they
it
do
is
with it?
because like it's almost. I grab it with a 2x2 and put it in a hazard bag, but I mean, it's almost like the patient is instantly feeling better.
Huh. No kidding. Okay.
I digress.
Very cool. Any other questions or comments?
If you get the leech, does that set your stopper? Is that your working length?
No.
Or is it shortened upon removal?
Is it shortened upon removal? No.
Or maybe lengthened upon removal. I don't know, but
probably length.
I've heard it's exciting if it does happen.
Between a coronal and apical reference point. And typically in the coronal region, you're going to be using a cusp tip. And then in the apical region, it is the apical constriction. All right. So getting into the reference point, this is going to be the site on the occlusal or incisal surface from which measurements are made. And it's the point used throughout canal prep and obturation. When it comes to selection, a reference point is chosen that is stable and easily visualized during preparation. For anterior teeth, this is usually the highest point on the incisal edge. For posterior teeth, this is usually a buccal cusp tip. And then the same goes for all canals and multi-rooted teeth. And then the MB or mesobuccal cusp tip is preferred in molars. So here's a diagram comparing a diagonal surface of that of which is A to a flattened surface which is B. And so as you can see here, flattening the two surface which is B allows the stopper to easily rest on that surface, so it helps avoid errors and will give you a more accurate reading or a more accurate site of reference. So if you can see my cursor here, actually B with being a flat surface, the follow actually goes farther down towards the apex if you look at the difference between that of A. And that's just all, this diagonal surface should be flattened to give that more accurate site of reference. And that's how that diagram is showing you. Here's the different anatomy of what we're dealing with here in terms of the apical constriction. And then we also have the apical foramen and the radiographic apex, which is about 1 to 2 millimeters away from each other. And here we have the anatomic apex. And this is going to be the tip or the end of the root determined morphologically. All right, whereas the radiographic apex is the tip or end of the root determined radiographically. So I'll show my cursor. If you guys see my screen, like right around here would be the anatomic apex, and then right here would be the radiographic apex. And then moving it over here kind of fades away a little bit. I would say right around here would be the anatomic apex, and then right here would be the radiographic apex, if that makes sense. In terms of apical constriction, All right. I know Dr. Gray touched on a few of these terms already, so it's good that we're going through it again. So this is also known as the minor apical diameter, and this is going to be the apical portion of the root canal having the narrowest diameter. And this position will vary, usually about 0.5 to 1 millimeter short of the center of the apical foramen. And this diagram will show you, I wrote down in my notes, Dr. Gray said that where everything kind of comes together. And that's where the arrow's showing you right there. And that's the apical constriction. And then we have the apical foramen. And this is sometimes referred to as the major apical diameter. And essentially it's the opening at the apex of the root of a tooth through which the nerve and blood vessels that supply the dental pulp pass. And this is located from the anatomic or the radiographic apex. So here's another diagram to show you guys that. And then with that being said, I'm going to kick it over to Kelting. He's going to go over the different techniques and methods when determining working length.
Thanks, Jason. Great job. I appreciate it. We'll go into next slide, please. So here are the three common methods to determining your working length. One is a tactile determination. We'll get into a little bit. Next is an X-ray in conjunction with the final one, which is your apex locator. Next slide. So tactile determination is kind of like what Laurie and Sonia were talking about earlier, the tactile sense that you get with a hand file. This method is almost obsolete anymore alone by itself. This is what they used to do way back in the day before x-rays. So not much to really get into on this one. If we could go to the next slide, this is where the x-ray would come in to play. And most likely we use, or most common technique with the root canal therapy, apical constriction is not exactly visible on the x-ray. You can see that the position of the apical constriction is assumed in a distance 1 to 2 millimeters away. So there's still a little bit of play from the radiographic apex. And in this area of the tip, the file should be visible on the x-ray. This is where, if you go to the next slide, with the advent of the apex locators, like Dr. Gray had mentioned, this just gives you better localization of the apical constriction, and it just gives you a better idea of what working length more accurate rendition of what your working length is. Apex locators work with a voltage source and measure it in a measuring instrument. So the file serves as the electrode and the measuring instrument. And then the counter electrode, I don't know why I'm talking with my hands because you guys can't see me. The counter electrode is the lip clip, which is placed on the corner of the patient's mouth, as you may or may not have seen or demonstrated with some of your customers. It is important to operate in a wet. However, as you may know, with our apex locator, it can operate in a wet or a dry canal. Most of the other apex locators out there they can only work in a wet canal. So, but it's optimal if you can do that because you get a better current flow. And then the working length is determined by electrical resistance and measuring, and the resistance is at its highest at the apical constriction. So, next slide. If you can go back, one thing that we most certainly always recommend is that you still take an image or with an x-ray just to confirm as well. So the advantages of using an apex locator, as you can see, it's easy and a fast procedure. You can control the working length without any additional x-ray exposure, so you don't have to take multiple x-rays. You can just take the final x-ray at the end. You determine the working length during patency, and it just gives you that extra security. Next slide. So here's just a slide that we put together on the step-by-step procedure. First steps are important. Use of dental dam, and we already went over isolation. Should always be used in the case of an endodontic procedure. You hear Gray talk about it as well. He doesn't know any endodontists, or he thinks GPs are crazy if they're not using dental dam, because it helps prevent visibility, and then it helps keep the everything isolated. Coronal enlargement with the orifice opener or the Gates-Glidden burrs. We would prefer the orifice opener because that's what we sell, but again, it is doctor's preference on that. Scouting of the canals through the with the K-files, as we just went over. And then also I would say another important part with the Gates-Glidden would be what Jeff and Melissa went over, which would be your access. And then after the endodontic length is determined, again, we still recommend that you take an x-ray. That's where you would go into what Meredith and Brad were talking about with the preparation of the root canals, considering the determination of the working length. Next slide. Why is an x-ray necessary? I've gone over it a couple times already. It's just basically a security blanket. It just ensures that you have covered all your bases essentially. And also, an apex locator doesn't tell you how the curve of the canal is, where the additional canals are, the patency of the canal, or how straight your access is. As much as I love our x-ray and I say it gives you a virtual rendition of the canal, it kind of does, but it really doesn't. So next slide, please. In conclusion, the current combination of using an apex locator and x-ray provides the best results in determining your working lengths. Next, we have a couple of the our Canal Pro Apex locator. As you can see, it fully automatic. It's very accurate in the measurement. You see some of the other features as far as the virtual apex, audio feedback, rechargeable battery. It's portable, which pretty much they all are anyways. And excuse me. And it does have a 2-year warranty for the life of the unit. And then we have our competitive analysis. You can see that we are right in the ballpark with some of your more current apex locators, J. Marita being the most popular one because it's been out on the market the longest and kind of revolutionized the apex locator market. Next slide. Here are references that we used. The Canal Pro Apex Locator demo video, and then we used another power with some other references. So, any questions? Anybody? Am I all alone?
No, great job, you guys. Excellent work. Thank you.
What the hell?
Right.
For the last 10 minutes.
Just imagining you talking to air, moving your hands around.
Yeah.
Showing everybody where the apex is. Kuda, great job. Yeah, I mean, again, just some great points in there. You know, I feel like the more we learn about the difference between a radiographic apex and the anatomical apex, it's like everything that you guys were talking about and everything Gray was talking about. It's like you just got to, you can't use the radiographic apex for anything except for maybe like a insurance image reference. But do you guys remember what Gray said as far as files being too long? What % of cases where the working file is usually too long?
I want to say it was like 90. Like 90%
That's exactly
of
right.
the time. Was it?
It's exactly, yep. Working file is usually long 90% of the time. If the working file is at the radiographic apex on the PA, subtract 1 millimeter from the working length. So the radiographic apex is not where the apical foramen is located. Dr. Gray showed that awesome picture of the file, 2 millimeters outside of the apex. And it's like, it's so damn scary, right? Especially if the next thing you're going to do is flood that canal with sodium hypochlorite. It's like, every office that's doing endo needs an apex locator. They need to use it all the time. If you have a doctor that says, I just take multiple x-rays, just stop them. Start asking questions about, how they determine where the anatomical apex is and the apical constriction. So anyway, again, just great job reiterating all that. And then Celts, you're talking about tactile feel, the x-ray, bring back 1 to 2 millimeters. I mean, it's like, it's a variable, right? Like, what is it?
Yeah.
Like, if you're using an x-ray, what do you, is it 1 millimeter, 2, 1.5 millimeters? I mean, it's something that, really, you have to have some tough conversations about how they're determining the overall working length of a canal. And then troubleshooting, I had a couple other comments about it, and I think Gray hit on this as well. Using in a wet canal, Celts, how would you respond? How do you respond to that when you get asked about dry canals, wet canals?
Well, I mean, I mentioned that ours is suitable for both. Work in both. However, it could be, I mean, if it's overly saturated, like if it's like filled to the brim, flooded, it's not going to be as accurate. You know what I mean? It's not saying it needs to be a flooded canal. I mean, none of them are really going to work that well in a flooded situation, even ours. But because you're going to have blood, you're going to have other things that are going to pop up, after you suction. If you have I mean, I've watched Meredith's video, and that guy was bleeding like a stuck hog, So, not to use an Iowa reference, I guess, but so yeah, you just get a little bit more. You're going to get more accuracy out of ours than you would out of some where it has to be completely dry.
Okay. So a moist canal?
Sure. As much as people hate that word, sure, moist.
Yeah, I guess some people do hate that word. I don't know why. Anyway, all right. And then you hit on a couple other key points with better accuracy using the correct size file. Can you hit on that again? Like an 06 or for a narrow canal, or a larger canal, what size file and how that's going to affect accuracy?
Let's see. I forgot what slide that was on.
It's like 3 back. No, it's more than that. There it is. Good job. Tight canals. Yep.
So the ISO 6 or ISO 8. Well, I mean, tighter canals, you want a smaller file, right? You want something that's going to work its way in there to give you a more accurate reading. I mean, if you have a large file that's too large and it doesn't go all the way down, how do you know that you're all the way to the bottom of your apex, right? Unless you take an X-ray and
Exactly.
then you. So.
But then, so I think something that Gray was alluding to was that, you've got let's say you got your 06 connected to your apex locator, and that's what you just constantly, regardless of what canal you're in, that's your go-to apex locator file.
Sure.
I believe what he was saying, you guys correct me if I'm wrong, but for a larger canal, you may actually get a less accurate reading by using a very small file. So you should change that file out for a 15 to increase the accuracy of the apex locator. Does that sound right?
Yep. Like there's
I
more
always
surface.
say that you need something. Yes, I always say that you need something large enough to touch the walls to get a more accurate reading for those molars.
Okay. All right, good. And then last thing is, I think Gray hit on this as well, was, you unplug the lip clip from the apex locator between teeth. So if you've got a patient that needs endo on 2 different teeth, for that first tooth, you would have the apex locator in the off position, unplug the lip clip connection, and then you turn it on and then you plug it in. That's right. And that's going to recalibrate the apex locator for that individual's tooth and from one patient to the next. I think that's a big thing,
That? Yeah. Does everybody always go through that when you sell that? One of the troubleshooting things ahead of it before you get the call that it's not working? What's your wording? How do you go through that?
You mean when you like to show the 2 arrows that come together, or like recalibrating it?
Yeah, recalibrating it. How do you go through that to troubleshoot so we don't have any issues? I'm saying, how do you
You just
go through it?
You need to unplug it so that it does recalibrate it. You don't want it to have the memory of the last tooth that you worked on. That's all I say.
Yes. Nice.
Then,
so once the new tooth comes up on the screen, then you plug it in.
Yes.
All right.
Okay. Great point. Thank you, Meredith. So anyway, you guys did a fantastic job. Lots of thoughts, lots of questions. But I feel like files are going to be the thing that we are focused on the most, selling the most of. But maybe a close second is apex locators. Something that there's a lot of room out there to capture business. There's a lot of old Root ZX out there. You heard Gray talk about how that thing bounces around. So again, this is something that you're going to get questions about, knowing it frontwards, backwards, being able to troubleshoot it. Those are all things that are going to just help you sell more of these and be able to service them in the field and take care of your customers. All right, that's it for me. Any other questions or comments?
One thing from me, Kelting or whoever's driving, can you go back to the slide that has a picture of our apex locator? I think that it's important to understand and go through. And now that you guys are the experts on the apex locator, Kuda and Kelting, maybe you can walk us through it. But if we have 11 segments now, and I'm totally not the expert on talking about this because it was like an aha moment from Dr. Gray about the apical zone. So 11 segments there and the 3 different colors, right? So can you guys get into the different colors and what they mean and how we should be talking about this in front of the doctor and what that actually means? Because the extent what I was talking about in the field was there's the M button, and we can set that 0.5 millimeters shy of the apex, okay? But now it all makes more sense when we talk about the apical constrictor and the theoretical area and the foramen, yada, yada. Can you get into a little bit of more info on that?
I'll tell you what, do you mind if I show Gray's slide that was talking about that?
Oh yeah, do it.
Is that okay?
Absolutely not.
Damn it.
No, please do.
Make me the presenter. Yep. All right. So this is what Rick was talking about and what Meredith is alluding to. So apical constriction equals area of the 3 green bars. So, I'm such a terrible rep, but I would say, yep, and the color goes from blue to green to yellow to red as you get closer to the apex, doctor. But what does that really mean? So the working length again is the apical constriction is marked by these 3 green bars here. And then the apical foramen is on that 3rd green bar. Is that right, Meredith?
Yes, it would start the first yellow bar.
Correct.
Start the first yellow bar. Okay.
Yeah, so the first yellow bar is where we're going to shoot for, right? But the best practice is to take it all the way down till it says apex and then pull it back. So it's almost kind of measuring till when we get to the very end of the apex, or we're through the apex, and then we're going to pull back and be in the general area of the yellow. I think it's just a really good slide to know, and you're just bringing more information to the doctor because they understand this, but just for them to understand, okay, this is how exact and precise you're going to get with this device. And it's $50 more than a J. Marita. Come on, it's a no-brainer.
Yeah. But I feel like if every time you're taking a file to red, you're one of those 90% out of the actual apical foramen.
Yeah, and those 90% could have been everybody who I've talked to already, because that to me was where we needed to be, but it's really not. So I just love the better understanding that we got. That's my tidbit. Thanks, guys.
Thank you for your honesty, Meredith, and I think I share that same ignorance. And yeah, I'm regretting a lot of what I've said in the past. But does anybody have any questions about any parts of that? And the importance of being able to set that virtual apex on the apex locator. I mean, I think you should do that with every single patient, right? Every canal.
Yeah.
Meredith, am I crazy?
No. Absolutely, 100%. It should be at least to the 3rd yellow bar and be able to get into the conversation of why. I mean, show them how it goes to the apex, and then hit the M, hit the virtual. This is why I'm bringing it up to at least the yellow, whichever bar, and be able to have that conversation of the apical constriction and the apical foramen.
Agreed.
I have a question though.
Good job, you guys.
Hey, does it always
short
show?
Question, Pearson. Go ahead.
Does it always show 3 green and 3 yellow? I thought that was dependent upon the measurement of the tooth?
Nope. It's always 3 green, 3 yellow, 1 red.
Okay.
And I mean, that's a good point because, I mean, if we could have this customized to like be able to completely read like the anatomy of each tooth, that would be nice. But because the apical constriction, that's the part where it varies as we age, right? Because that theoretical area gets smaller as we age. So it's just kind of a guesstimate. But no, it's always 3 and 3.
Yeah, I mean, you know, back to what we were saying about, you know, what Kuda was talking about being a millimeter shy of the apical foramen. I mean, that's all the way up in the blue. So, and I think that that green area as known as the apical constriction is that's a pretty good rule of thumb. But
And Pete, you got to think radiographically. You're going to be looking at the bottom of that tooth radiographically, so that's going to be another like 3 millimeters beyond where that red dot is, don't you think? If you're looking at an X-ray. So then you would probably be about in the green zone.
Yeah.
Hey Pete, can we have this queued up for Monday with Dr. Albors to really dive into it?
I was just going to say,
Sure.
Dr. Albors, I remember at Midwinter a couple years ago said he does the exact same thing. From what I recall, he takes it to the apex and then backs it up to the second green line. So that's what I've always told offices: take it to the apex and back it up to that second green line. And Dr. Gray, I believe, said the third green line. So I mean, either way.
So again, yeah.
You've been doing it right, Laurie. Thank you.
Yes, thank you, Laurie. You don't have to be embarrassed like I am. I'm going to go bury my head in the sand. Any other questions or comments? All right, guys. Well, thank you for putting in the extra time today to knock all those out. Let's get started tomorrow morning, 9:30 Eastern, 8:30 Central, and we'll knock out 3 more. If there's any questions, reach out to me. If not, have a great night. Thanks, guys.